Easy, there's Africa Reach. But it needs to be. Dr. Agnes. Agnes. Needs to be facing them. That's your banner, it needs to face. Yeah, they need to. People are coming. What I was hoping it's going to be bigger than this. Yeah, I was actually, the venue is not cool. We should have been inside. And it's actually a problem because we're a sponsor, and I don't understand why we got this. But anyway, it is what it is. I'm going to start. Okay. Yeah. Okay. Yeah. Good afternoon, ladies and gentlemen, and welcome to this afternoon's VIIV sponsored symposium. And thank you very much for braving yourselves under this heat and coming to sit with us in this tent. And I'm sure all of you are extremely hot, but I promise you with the energy that will unfold, it will even get hotter, but hopefully we'll leave smiling at the end of this. So without further ado, I'm going to introduce myself first. I'm Dr. Ismail Ibrahim. I work for VIIV Healthcare. I'm based in Cape Town, and I'm part of the medical affairs team. And thank you again for joining us this afternoon. So I thought just before kicking us off and setting the stage, and I thought about sharing a reflection, a personal reflection about myself. So I speak about back in the day in the early 2000s, as a medical doctor, treating patients with HIV and being forced to just put them on a bed, leaving them to the back and the side of the ward, closing the curtains and leaving them because there was very few options, and then leaving them to succumb to death and having to explain that to the family. So we've come a long way since, but this could not have been possible without each and every one of you and people like you, mentors before us that have led the path for us to go forward. So I think it's important to also to celebrate the successes. Yes, we have not arrived. Yes, the journey is far. But if you look at the 2023 UNAIDS data, because of the intervention of antiretroviral therapy and education and awareness and all advocacy, we are able to avert 3.4 million HIV-related infections in children. And in addition, because of antiretroviral therapy, we have managed to, based on modeling, to avert plus minus 20 million HIV-related deaths. And this now brings us to this afternoon's conversation, where I want to share with you that despite the successes, we have a far journey to go ahead. Yes, we have a common Northern Star. We all have the ambition to end the HIV epidemic, and it can only be done together. When one looks at pediatric HIV care, you realize that there are disparities within care in terms of adult care versus pediatric care. In kids, for example, just knowing your HIV status, the understanding of this is low. Kids being on antiretroviral therapy, very few versus adults, if you look at the percentage, and also being virologically suppressed. There's also big disparities if you compare to adult care. So this now, just to highlight the objectives of the session, I want to say that this session is all about you. It's all about listening to the fantastic panel as well. But I do encourage, we're a close, small family that's here, so please ask questions. And it's hopefully, I'm hoping to provide a platform to see the different challenges to various perspectives. For example, we've got Dr. Leon Levine, who provides the clinical perspective. We've got Dr. Agnes as well, who provides as a public health policy expert, and she provides that perspective. And then we've got Anna, who is an advocate in the HIV space, working for GMP+. Okay, without further ado, please welcome Dr. Leon Levine to the platform.
Thanks very much, and thanks for inviting me to speak. I hope you can hear me because I've got to face the screen and face away from you. Okay, so look, I've been treating children with HIV for the last 27 years. Things have changed dramatically since I started, in keeping with what Ismail is saying. These are my disclosures. So we've all had major changes. You cannot believe it, unless you've been around, how we struggled for all those years with terrible formulations. We've now got the pediatric formulations. They're unbelievable. Okay, so why do we need community partnerships? Because despite having these amazing formulations, we are still not there yet. Okay, in terms of 95, 95, 95, which you all know pretty well. So the first 95, where I can't read the numbers, I'm afraid you're going to have to read it because of this angle. You can see the marked contrast between adults in blue and children in green. People, the first 95, second 95, you can see once again a marked contrast, and similarly with the third 95. I'm sorry, I can't read the numbers from here. 44% in children, looks like 74% in adults. So we are just not there yet. Okay, despite finally having these fantastic formulations. I'm from South Africa. We've only had them for the last year or two. You guys in the rest of Africa had it for a few more years, and we're still not there yet. So why not? And what can we do about it? So let's look at the first 95, finding our children with HIV. So first of all, our community partners can help us with index testing. When an adult who's got the disease, go out in the community and find all their children, find all their contacts. Those older adolescents who are sexually active, contact tracing as well. Risk screening, there are numerous screening tools around. In South Africa, we're piloting one now which is based only on the mother's status, and that has been validated. So it's not difficult to do these things. You can also obviously asking about the child's health, and then testing in the community. We are having problems. And I think something we can discuss later on. Our community partners are often very uncomfortable testing children. There are consent issues. What do you do if the mother's at work and you've got a grandmother or a caregiver at home? Can they give consent to do testing? Something we need to discuss. Community partners are often anxious to tell a young child that they've got HIV. I would be anxious as well. I mean, it's very difficult to do. But if they can't do the actual testing, at least let them guide the clients to a facility where they can be tested and make sure that there is that connection. They're not just left there and the testing never takes place. So the second 95, starting and maintaining children at heart, so our community partners can help by making sure that those who are test positive are linked and initiate ART, facilitating same-day initiation. They can also follow up on the PCR positives in South Africa. I don't know if you heard about it, if it's been mentioned at this conference. We have an amazing PCR results for action where the laboratory actually sends out all the positive PCRs from the week before to your, depending on, you can ask for your facility, for your district, for your province, and you can then follow up. We can ask our community partners to follow up on those positives. Readiness counseling and tailored adherence support, and tracking and tracing patients with missed appointments, and even further down the line, tracking those who are lost to follow up. And also disclosure support and education. And then in the third 95, how can they help us, making sure the virus remains suppressed by educating about these new optimized treatment formulations that we have, by giving adherence support, so disclosure, which I'll talk about now, psychosocial support and referrals, and support groups with a peer-led, which would be ideal, but if not, just support groups in general. I want to talk a little bit about adolescent disclosure because that's something I've been very much involved in. So the bottom line is that us as clinicians and the parents are petrified about disclosing to these children. The parents who can understand issues of guilt, issues of that the child's going to be angry with them, issues of the child is going to disclose to all their friends about it. So the big issues. I'm not sure why we're scared to, but we are. As clinicians, we are petrified. Nobody wants to disclose. In South Africa, our school system wreaks absolute havoc. Why? Because they've hijacked HIV. Because HIV is now used to teach children not to be promiscuous. So they tell them they're going to die from HIV and that only bad or promiscuous people get HIV. So the minute you tell this child that they've got HIV, you're whacking them on the head and they will hear nothing else you're going to tell them, because now you're telling them they're going to die and that they're a bad person. So it's not so straightforward. So it's all very well to tell the parents go and disclose. It's actually the skill to disclose, because what you actually have to do is you have to teach the child the correct facts about HIV before you actually give the diagnosis. And there's no ways, of course, a parent is going to be able to do that. That's something that's only someone who's skilled who can do that. So this has to be done expertly. And obviously, we rely on our community partner to help with disclosure, but really disclosure should be done by everybody, from the clinicians all the way down. We should all be disclosing to these patients. Other roles for community partners, I'm not going to go into detail about it, but I think we can discuss it. I'm not going to, you can just read quickly what I've got there. I'm not going to go through it in detail, just in the interest of saving time. We can discuss it later. Okay, in terms of demand creation, this is something that we very recently sort of embarked on, because our partners are in the community. They're there working with the community. They've often got WhatsApp groups of all their clients. It's very easy for them to send out messages. And there are many things that could be applicable. Example, that we did it for the new ROVs, the new paediatric dolutegravir. We prepared a little notification that they could send out to all their patients, giving information about that. But other things, TPT, new vaccines, anything that's new and you want demand creation, you can certainly use your partners. And so our partners have got a WhatsApp group. They just sent it all out to everybody. In the interest of time, I'm not showing you what we sent out, but we can discuss it later. It's also very important to work well with your community partner. The thing about working with community partners, it's not a question of us and them in silos. We have to work together. It involves a lot of communication, both between us and them. We have numerous meetings, we have data reviews and joint clinics, and we have advanced clinics where we are there, plus the partner is there doing disclosure, doing adherence talks and all that. We've given them trainings. Communication, as we said, is absolutely crucial. You need to be communicating both ways. We've got bidirectional linkage registers where we would write down from our side what's needed from our partner. They would write down feedback on what's needed from us. And you need to have two-way communication. So to summarize, and I'm 7 minutes, 27 seconds. All these years, we've been waiting for the new pediatric formulations as answers to our prayers. Now they are there. We realize that they do make a major difference, okay, but they're not enough. Okay, we need our community partners. They are really in the community where the patients are, and they can help us against our 95 goals. But it's not just about goals on paper. It's about patients. Okay, it's about helping our young people to lead long, productive, healthy lives where they will not spread HIV because of U equals U. They can get married, have children, have a career like everybody else. It's not just yes, the 95 is important. But at the end of the day, it's the patient that is most important, and we really need our community partners to help us to achieve that. Just want to finish off, just thank acknowledgements, and finish off with just a little bit of an advert, if you don't mind. I am involved in an African advanced pediatric HIV clinic, which is run virtually once a month. If you're interested, you can scan the QR code, or you can take a photograph of that URL. Puts you onto a WhatsApp group, and we put notifications of the next meeting on that. We've already had ours last week, so the next one's going to be end of January. Okay, thank you very much.
Thanks, Dr. Levine, for sharing that, and just making a comment on this monthly calls that he does have. So it's quite interesting because it invites various clinicians from various places around Africa where they share complex cases, and it's a platform to educate young doctors and clinicians to ask any questions as well. So please, I encourage you to reach out.
And to get advice on your patients. So dual role, education and helping with your patients.
Thanks, Dr. Levine. So before I move on to Dr. Agnes Maumva, who is a public healthcare specialist, she's based here in Harare. She serves on the Africa Reach Leadership Council, as you can see on the left-hand side. So what is Africa Reach? Africa Reach is an African-led organization. It's a focus initiative intended to unify and amplify political forces. And to do what? So that together as an African continent, we are able to achieve the eradication of AIDS or HIV and have an African-free generation of children. So Dr. Agnes, can you maybe please just touch on what Dr. Levine was speaking about in terms of the challenges from a public policy perspective in terms of your lens that you could maybe share with the audience this afternoon. Welcome. Thank you.
Thank you so much. And I want to thank Leon for that excellent, very concise presentation that covers everything that really needs to be known, especially when you're looking at dealing with the patients, the clinical aspects. Some of the challenges are actually already coming out there. But as you point out, many times we really need to also look at that policy, the higher level, and say what exactly are the things that are making us struggle to reach those the 95 for children and so on. And in my mind, there are a few points that I sort of jotted down for myself. First of all, there's really limited, meaningful collaboration. You can do all sorts of things as an organization, as an individual clinician, and so on. But there's just that need to really collaborate and ensure that we will get to that far end. Yes, at individual level, looking at those detailed clinical issues and so on, it's very important. But there is that African saying which says, if you want to go fast, go alone. But if you want to go far, to reach those targets that we're talking about, we've got to get together. And I cannot overemphasize enough in terms of us collaborating meaningfully. What is it that we need to do? Many times we talk about it and we think, well, we have met, we have exchanged cards and so on. But are we also asking ourselves, have we set the, what I call the measurable indicators that tell us whether we are really collaborating or not? That's another point that I want to point out, that we don't seem to have any indicator or anything that will help us see whether we are actually collaborating well enough. He did touch quite a lot on the community approach. That's another challenge we have. The community-centric approaches are poorly supported. There's so many good initiatives in the communities there. I know we have the Y+ Global initiative that really speaks to the youth in the communities working together to advance that advocacy on pediatric and youth HIV issues and so on. But is it well supported? Can we not form other initiatives such as that can actually help us move further and move? So you're looking at the challenge in terms of supporting the youth themselves, the communities themselves, the collaborations meaningful in terms of the bigger and broader picture. The health systems that we're looking at, we are struggling because they're not children friendly. When we look at them, we address the issues that address the needs of the adults, but we're not always addressing the issues of the children. That to me is one great big challenge that we need to address. The Africa Reach is really very proud because we have really started moving forward, collaborating with other partners to make sure that we are indeed paying attention, giving a little bit of that support for the health system strengthening. We work with PATA, for example, that is very, very, very strong at educating, capacity building healthcare workers. Just one component of those 6 health systems pillars that we talk about, the HR component. We need to, if you're looking at the issues that Leon talked about, it has to do with the healthcare workers appreciating and knowing how to really step up and do more to address some of those issues that he talked about. And of course, coming to the big policy issue, the leadership, the policy, the financing of the issues that we're talking about is critical. And when you talk leadership and policy, it's not just at this high level where I am sort of sitting and discussing with the principals and so on. It's leadership at all levels in order for us to be able to reach that. So I think it's so important, and leadership can be sort of marked by how we set aside financing, domestic funding, for example. If you're looking at that higher level, are we prioritizing funding for these issues that we're talking about? What is it that we need to do? And that's a challenge to me because we are not really doing that. And of course, I think I could go on and on and on, but I think maybe those are the few things that came to my mind to say, how can we do that? And they are the main challenges in my mind. Thank you.
Dr. Agnes, thank you very much for sharing that perspective. Just want to say child-friendlier services. And I want to share something that I heard from an adolescent way back, and she shared with me, she said, if only childcare could be more sexier, more appealing, more friendly, why does it have to be so scary? So I'm going to leave that thought with you for now. And then I'm going to step on to our next panelist this afternoon, who is Ms. Anna Sango. She's an HIV advocate. She's got extensive experience in the space. She's got a keen interest on sexual and health and reproductive health, and also in young girls and adolescent girls as a key focus for her. She's currently coordinating a project with the EPIC initiative, the Mama Papa Bears initiative, where she's coordinating and leading. So let's welcome Anna as well, and asking her also the question, you know, from your perspective, through your lens, what are the challenges that you've seen that are coming through in terms of preventing or contributing towards this disparities that we see in pediatric and adolescent care? Thanks. Welcome.
Thank you so much, and I'm very happy to be here. So just looking at the presentation, it was really interesting seeing all the roles that community has played, community is expected to play, community is playing. And I was really thinking about who's paying for that. So our biggest challenge is really funding that. If we have to go into the community to index testing, we need to be able to support community cadres. And some of the challenges that have been there is really around that. Communities are working for free and it's unfair. We're not fully compensating them in these so-called partnerships that we have. So I think that always comes out as a big challenge. And because key players are there, different, coming from that side, come from that side, come from that side, others come with maybe higher stipends, others lower stipends, others no stipends at all. That becomes a bit haphazard and becomes challenging when it comes to engaging with communities. So for me, I feel funding has always been the biggest challenge in ensuring that communities do the work. But then again, I just want to highlight the amazing work that communities have also done with the very little, with the passion, with the determination that they have. There is so much that communities have done. I mean, when people were not speaking loudly about children, communities shouted, "Wake up, our children are dying." We developed the Kigali Declaration, which also led to a whole lot of a difference in terms of our pediatric HIV advocacy. And this is communities coming together. So I think when we look at partnerships, let's look at ensuring that we are legitimately supporting communities. And when we say communities, we're speaking of groups of people living with HIV. Let's understand the difference between AIDS service organizations, civil society, and networks of people living with HIV. I've often noticed that we get into a space and we say we're supporting communities, yet we're working with civil society organizations who in turn get the millions of dollars and in the back come to us as communities to do the work. That is very unfair. So I think we really need to define, when we say communities, what are we saying? A perfect example is to do with the community-led monitoring. This is an instrument that is supposed to be led by communities, for communities, with communities. But in many countries, you find that a lot of civil society and aid-serving organizations are leading within that. So that becomes a challenge. And also looking at initiatives and partnerships like that for the CLM, because we have the government, we have civil society, we have, different groups. We are not creating intentional and tangible platforms for collecting data on children. We really need to look in that. So I think there are also gaps within that and within the structure of that. So I'm just going to end here and give it back to you. Thank you.
Thanks, Anna, for sharing that perspective. Intentional and tangible partnerships. At this juncture, I'm gonna ask all of you. So, in the interest of time, so this is purposefully done in this way. So, we are hoping to encourage and invite a lot of questions on the platform to create an interactive kind of experience for all of you. So, at this stage, I'm gonna ask if there are any questions to the panelists, and if not, then we'll kick off the discussions with the suggested points on the slides. But I'm hoping that we get the engagement that we're looking for this afternoon. Okay, we've got one question.
Okay, good afternoon, everyone. My name is VIIV Nyamande, and I'm from Zimbabwe. I'm an epic champion, and I'm a young mentor mother. Okay, as young mentor mothers, I want to add on what Anna was saying. We are doing a voluntary work because I want to share my experience with some other young mothers there. And sometimes we need a motivation. And if I'm saying a motivation, you know what I'm saying. I am a mentor mother and I'm also a mother. So sometimes we'll be doing some home visits and I'll be doing some viral load checkups. I'll be doing some support groups. But when I have some motivation, I can do more than what I'm doing, because sometimes we'll be walking some long distances and I'll be working with those kind of young mothers who need more of motivation from me. But whilst I don't have the motivation and I don't have a motivation, I myself, it will be not easy for me to do those kind of work I am doing. So as an epic champion, as a mentor also, we are just paying with our donors or with whosoever, just to remember the community, just to remember those people are working with young mothers, those people that are working with the children. We are the ones who are monitoring those babies in the communities. Thank you.
So what I'll do is Dr. Levine has got a comment on that. So before we take the next question, if Dr. Levine can just respond, and then we'll take the next question.
Well, thanks very much. I actually disagree with you. I don't think you need motivation, because the bottom line is it's your job. You're working. Why should you just get a little stipend for doing work to motivate you? It's a proper job. It's very important, and things that need a proper salary, not just a little motivation. So I'm actually agreeing with you, but I just think it must be treated more than just a little motivation, more than just a little stipend, as I was saying. It's a proper job, and these people out there in the community need a salary, a proper salary.
So we'll take on that second question.
All right. Good afternoon. My name is Otina, and I'm also an epic champion. Just to support most of the things that have been said, yes, there's a lot of work that is being done in the community, and sometimes it's not being recognized. But now I want to understand, where are you guys, or whoever is doing the programming, putting the extended family? Like, as Africa, we know that in as much as we are targeting the kids or we are targeting the mothers, there's also need of extending the programming and including other family members that might not necessarily be HIV positive. Because when we look at most of the young mothers that come for testing and whatever it is, some discover their status is widely they are lactating or they are pregnant, but they also
It's fine. Maybe try without the mic if you can. Yes.
understanding that in as much as probably, let's say I am a young mother, I might be doing everything that probably the doctors or whoever the facility has illustrated and told me to do. They will also be of influence in everything that I'll be doing. Let's say I want to give probably my child nevirapine and everything, and I don't necessarily want to tell them about my status. And we are living in the same space and we are sharing whatever it is that we are sharing as a family, and I haven't disclosed it to them. It then means that these will distract my adherence level, and they will also distract the adherence level of my child. So I feel like in as much as we are talking of communities leading and everything that we are doing, let's also include extended families and understand that those new positives also need the support of extended families after leaving the facilities and after leaving the support that they are getting from other people that are not necessarily part of their families. Thank you.
Thanks for that contribution. Another comment in front.
I think I'll ask the person next to me to translate. Mina funa ukuthi Nomthika lento eshiwo ana it's a problematic because always like in a project Mothers for the Future from South Africa that survived since from 2013 until now. We didn't have a funding at all. We're living in donation. But into engifuna ukuyi-highlight ukuthi always ingane is a key population left behind because the criminalization, they affected about it. And then they could not able because the mother babu born themselves, they're not able to disclose their status. And then when it comes to disclose their children's status, my worry is that when they died and then no one knows about those children, we need to do a survey or a research around those key population children so that we can reach all those children, so that we can reach 95.
Okay, so the second part, I think for the most part we got, but the important thing with the first part is what Doc was reflecting on around disclosure and what Anna was reflecting on around the issue of funding, but the resilience of communities in continuing to do that work. Because Mothers for the Future is an initiative that is led and coordinated by mothers who are sex workers in South Africa. And the priority there is mothers who are sex workers, who are also primary caregivers. So parents and primary caregivers. So key population is encapsulating of those people. And so the concern is that with what you were reflecting on, Doc, around already clinicians and parents are nervous to disclose their status, it's layered for people who are from the key population community, particularly sex workers. There's criminalization and stigma attached to it. And so to have to disclose when already the children are being bullied in school and they're going through these different experiences of knowing and being told that their parents are sex workers, and then they have to disclose their status to their children. And in some instances, the parent will die without having done that. And so no one actually knows that the children is living with HIV. And so how do we navigate that conversation to ensure that we do not leave people behind, but we actually take seriously the fact that there's funding required, not for Mothers for the Future to exist from 2012 and still have to live on donations and drop-ins and have to really mobilize funds to do an NDA party for the kids. So what does it look like to really meaningfully involve key population, even in light of the current context that we are in around criminalization and some of the experiences that they have as a result of that, in as a layer to what has already been shared as some of the challenges that you're facing? Thanks.
Thank you very much for that very good question. I'm going to open it up to Anna. Maybe just if you could just share from your perspective, especially with regards to disclosure and the challenges with regards to parents. And then Dr. Levine's also got to add to that, but maybe from your lens, through your lens, if you could share something with regards to that.
Yeah, so the issue with disclosure is really a challenging issue. And I feel more because of the stigma and discrimination that's attached to it. Because as a parent, I mean, I'm a young mother, right? Okay, 36 is young, right? I'm a mother of 3 boys, 2 biological, and 1 is my stepson. And my stepson is living with HIV. And it was difficult when he got tested and we had to disclose. We had to find ways with the father in which we can tell him that this medication is important. You have to take it, because by then he was like 10. 10. So it was really kind of difficult to make him understand that we need him to take his medication, not stop taking his medication, because it's important, because there is a condition that he has that he needs to manage with that medication. Because we were fearful that if we fully disclose, most probably it can then have an impact either at school or in the community. Maybe he needs to run into the house and take his medication. People are asking, where are you going? Oh, I need to pop my pills, you know? So we had to come up with this. Even when we were among other relatives, I would just be like, did you pop? You know, so it was really difficult. But at the same time, he was also an individual who knew somehow that there is something, because he's at school. He's also open to like learning about HIV, you know. So he would like try to put the dots together, and it would be really, really confusing for him. So, but what we did, to cut the story short, we did it in layers. Like bit by bit, bit by bit, bit by bit, bit by bit, so that you can fully understand. But I also noticed a lot of parents are afraid to disclose because they're afraid the community will now know their status. So if they know that my child is HIV positive, they know that child came from me, which is I'm HIV positive. So it's always been a big, big challenge. And I feel the community really has a big role in terms of trying to help parents understand that, because what in turn would happen was children would think they're taking vitamins, and then probably when they get to 14 and 16, like, I don't need these vitamins. And they stopped it. Or they're going to boarding school. I don't need this. Or they just shy away from taking because everyone is not doing it. So why should they do it? And you know, all the other issues that come with puberty in adolescence. So I really think disclosure, we really need to work around how do we ensure that we disclose in a safe manner, and also how do the children disclose in a manner that will also be dignified and respectful of them as well. So it's really needs to be a lot of work that we need to do.
Thank you. I totally agree in terms of disclosing in a respectful manner. Dr. Levine.
Yeah, I was going to answer your question, but now I'm going to answer Anna's question, but I'll get onto yours. Okay, so look, disclosure is, it's there. We know how to disclose. Disclosure is a process. There's what we call partial disclosure and full disclosure. It's what you're describing, but that's well known, you know what I'm saying? And the important thing is not to lie to the child, not tell them they're taking vitamins. You've got to explain to them what why they're taking it, but without giving the name. That's your partial disclosure. You know what I'm saying? Then they know what's wrong with them. They know what happens if they don't take the treatment, but they don't know the actual name. And that's, it's obviously, obviously you done it a few years ago. This is involved in, and this works pretty well. And then full disclosure, it's done when a child's at an appropriate age. You're not going to just fully disclose to a 3-year-old, okay? Because the 3-year-old's going to bump his friend will bump his toes. I've got a sore toe. So what? I've got HIV. They don't know what it is, right? So you're only just going to disclose to a child who is mature enough to be able to understand. And part of the disclosure is stigma. You've got to, before I disclose a child, when I've finished, I'll explain about stigma. And you can't go and tell your friends, okay? You can't, even, if there's someone you want to discuss with your parents. Who's the suitable, do they know? Can we discuss it? So that's all part of the disclosure process. So if disclosure is done properly, those are not issues. The other thing is that I find in a lot of my private patients, which fits in with your patients, okay, it's different but it's similar, is that the private patients don't want the kids to know that they've got HIV for some reason. Why they're any different from anybody else? Okay, but it will be the same as your sex workers, right? And there are ways of disclosing. When I disclose to a child, the parents say to me, look, I don't want you to say, I'm not ready to say that they got it from me at this stage. Obviously, it will come with time. But at this stage, it's more important for the child to know their status. But it's not that important they know they get it from me. You understand? And so there are ways of disclosing to a child. We say, look, where do children get it from? Yes, they get it from their parents. They get it from breastfeeding. They can get it from pre-mastication of foods, sangoma, scarification, whatever, different possibilities, and we just leave it at that. So you don't have to say you got it from your mom if the mom's not ready for that disclosure. You can still disclose to the child without, and then the parents in their own time can then tell the child when they're ready. So there are ways around it. But I agree that, obviously, we talk about key pops, it does add an extra layer of complexity, but it doesn't change the fact. I also had another interesting one. We had a meeting with a transplant unit where they're considering doing transplants from HIV positive patients, and they said to us, we don't know how we can tell the patients. I said, we've been doing this for years. It's straightforward. You just disclose like everybody else. You just have to adjust it to the situation.
Thanks, Dr. Levine. I'm just going to take one more question from the floor and then to the panel. So we've got a question here in front, please.
Thank you very much. My name is Anne Selberg, and I work for Shandiri and the CAT program, the Community Adolescent Treatment Supporters. And we've also put a lot of effort into disclosure, but I'd just like to pose this question to the team, because it's like you say, Dr. Levine, that we know how to disclose, we know it's important for viral load suppression, we know it's important for mental health, and yet we're talking about new optimized treatment, and we have this wonder pill, which is disclosure, but we're not rolling it out across all the countries are facing challenges. Why is there not more focus on disclosure, and why is there not more tracking and monitoring and funding going into disclosure? Thank you.
That's a very quick question. Dr. Agnes, maybe if you could try and answer part of that.
Thank you so much. Those are very good points. But before I come to you, I want to just quickly understand the lady who said motivation, and you really said you don't need motivation. It sounds to me like she was really talking not motivation as such, but as financial support to be able to do work, because a lot of the people are volunteers who get sometimes a stipend which is not adequate for that bus fare, for that what have you, and so they are unable to do the work. I hope I'm correct when I'm saying that it's really not. So maybe the terminology used, motivation, might make people think exactly. So it is important. But you mentioned funding for addressing a number of the challenges that you brought about. It is one of the reasons why we are saying, yes, programs, they are very much dependent on funding from the north and so on and so on. It's high time we bring stronger leadership. This is why I said at all levels, which includes us prioritizing some of that domestic funding to support those kind of issues. If we continue depending on other people to provide funding, to support disclosure activities and so on, we'll probably not get where we want to go. So I don't know if I'm answering your question comprehensively, but I do think it actually hinges on that leadership at all levels, and indeed us prioritizing some domestic funding, not just depend on our partners, to really then be able to strategically address those priorities, especially the one you just mentioned. Thank you.
In the interest of time, I mean, unless there's one last burning question, I'm going to leave it to the panelists just to give their last take-home messages, and then I'll close off officially. Are there any other questions from anyone? Last burning question? No hands, no takers. Thank you. I'm going to ask the panelists just to maybe give a take-home message, one message through your lens. I mean, and yeah, before I close.
I'm first. So I think my key takeaway would just be that really children cannot thrive without investment in communities. We really need to be intentional in terms of supporting the work of communities. We need to professionalize the work of communities. We need to compensate them so that they can be able to do the work, because it is a lot of work, and after all, they are human. So I think that's one of my takeaway messages. And then my other takeaway message, really, it's going to partners and funders. It's really around our language and tone when we are engaging with people living with HIV and communities in general. I think sometimes we may be privileged enough to be knowledgeable, to be experts, but we also need to understand that this is a human issue, this is a human problem, and the people facing it are the humans. I always say the first H in HIV, it's human. So we need to understand that we are people, we have realities, and sometimes our realities are not really the same given our geographical location and also our professions. So I think language and tone in terms of our partners really needs to be more supportive and more encouraging. Thank you.
My take-home message is really more biased, because I'm looking at where I am working and what are the issues I really need to pay attention to.